So next we're going to look at our tibial nerve. I like to start at the sciatic nerve and then move distally to see the tibial and common peroneal nerves branch. So here we are looking at our sciatic nerve, which is really a lot harder to see at this level. I'll come a little bit more distally. You can see as I toggle, that's our sciatic nerve in the middle. And then if we move a little more proximally, again, it's a little harder to see. Now we're going to move distally, but I'll just orient you here. We're approximately 5 centimeters above the popliteal fossa. As we move distally, following our sciatic, you can see right here is where it starts to split into the common peroneal and the tibial nerves. So on the right side of the screen is the common peroneal nerve coming off, and on the middle of the screen or left side is the tibial nerve. So now we're going to follow that tibial nerve as we go more distally, and it's coming more superficial. And we can see that I'm on the back of the femoral condyles now. And you can see our popliteal artery really nicely deeper below. And I'll just toggle to try and get our best view of the tibial nerve. And then we're going to move more distally. And already we can see the gastroc muscles coming in on the top view. The left is our medial and the right is our lateral. And our tibial nerve is in between the two. So we're going to pay attention for branches going to the gastroc. And even now we can see them splitting off. So on the left side, I'll scroll proximally again. You can see the vessel and distally, and our nerves run with our neurovascular bundle. So we would inject in that plane to try and block our medial gastrocnemius branch from the tibial nerve. And then looking at the lateral, again coming more proximally where it's the full tibial nerve, and then you can see it branching off here. The vessels are very nicely visible in that fascial plane where we'd expect that branch to the lateral gastrocnemius head to run. And so scanning again distally, and then again proximally as it comes closer to the actual tibial nerve, and distal again you can see it branching. That's often how I try to identify things, is by scanning distally and proximally. And then if we go back to our center, it's a lot harder to try and see the branches to soleus, but they do come off quite proximally. So we'll follow distally. And there are a few more branches here, but these ones actually, if we follow this neurovascular bundle, looks like it actually goes to the lateral gastrocnemius head. As we go more distally, you can see those vessels go into the lateral gastroc. But in this view here, I see a bright area of fascia within the soleus muscle that I wonder if this is our branch to soleus. So I'm going to follow it again proximally, and I can see it coming up almost in between the fascia connecting gastroc and soleus. And I could convince myself that that might be the branch, although it's a bit harder to follow proximally as I try and go closer to the tibial nerve. You can't really follow it as easily. So coming again distally, harder to follow, but as we get more distal, then I can see the fascial plane between the gastroc and the soleus better, and I can convince myself that there is a branch coming from that fascial plane into the soleus. So the most important part of these nerve blocks, when you're not sure based off of ultrasound, again, is to use the nerve stimulator. We would target this branch to what we think is the soleus and see if we can get good soleus contraction. And this would be a very nice medial to lateral approach in plane, so I'll demonstrate that now. Coming medial to lateral, an approximate 45-degree angle to reach that branch. And similarly, I'll demonstrate the approach more proximally for the branches to the gastroc. You can see them both nicely here. You could come either direction for these. We can move it more into the middle of the screen and find our best view, and come medial to lateral for this. Alternatively, you could come lateral to medial, moving the view over so it's closer to the right side of your screen, and then again coming lateral to medial in plane to target that area. And then if we want to block the lateral, or the branch to lateral gastrocnemius, similarly we could come medial or lateral in plane. So we can see it really nicely there in the middle of the screen. And now we can come lateral to medial again in plane. You can see the indentation. Or again, we can come medial to lateral, moving it closer to the left side of our screen. So we'll show you the muscles of the posterior compartment when the patient is lying prone, which some of us may inject in this position and some of us may not. So in this view, you can see the very end of the medial and lateral gastroc heads, and then beneath there is primarily soleus. So we'll move more distally to see our deeper compartment muscles, and you can see them starting to come into view a little better. This here is our fibula coming into view. So just medial to that on the left of the screen is our FHL. So I'm going to move the patient's big toe, and you can see that FHL moving. And then above our fibula and more to the right of the screen, these are our perineal muscles. So we want to make sure we're not hitting those when we inject, obviously, because we'd cause foot eversion weakness, which patients typically already have. And then to look at FDL, we're going to slide over to our tibia here, and this is our tibia on the left coming into view, and then just inside that is our FDL. So we're going to move the toes here, and you can see that wiggling a bit. And then tib post is deep to all these. It is a little more evident when we're more distal, and it's in between. You can see just the shadows of the edge of the tibia and the fibula at the bottom here, and in between those is where our tib post sits. It's harder to see movement when we move the foot, but we can give it a go. It's harder to isolate that movement to demonstrate the tibialis posterior. But it sits between our FHL, which is over here, and our FDL, which is over here, and in the middle is our tib post. And then our soleus is still a partially muscle component, and it sits above everything else. Gets bigger as we go proximally, smaller as we go distally. And then I'll show you the tibial nerve here. We'll make sure we get a good view of it. Try and bring it out a little more. There we go. That's our tibial nerve, which if we follow it distally, it comes even closer to our medial malleolus. And we want to avoid that obviously when injecting. Moving more proximally, we can see it move in the middle. This is a great view of it, and we can see, looks like our neurovascular bundle next to it. We'll do color Doppler to show you that artery. Okay, and you can block the tibial nerve distally here to look at the component of the foot intrinsic muscles in playing a role in spasticity. However, we are usually doing blocks of the tibial nerve more proximally.